Hello everyone, welcome back to our second session for the morning, which is very topical, the intersection between long COVID and other post-viral illnesses. I think our next speaker is in high demand with long COVID coming up as quite a big issue in the community. We're lucky enough to have Dr. Richard Schlerfeld today, who's an expert in this area. I'll tell you a little bit about Dr. Schlerfeld. He graduated from Uni of New South Wales in 1978 and he started his career in ICU, but then moved into general practice. Since doing general practice, Dr. Schlerfeld has specialised in complex and chronic disorders, particularly myalgic encephalomyelitis and chronic fatigue syndrome. And as we know now that these have a lot in common with long COVID. Richard has received numerous awards, including an Order of Australia for service to medicine. In 2020, he was appointed a senior lecturer at Macquarie Uni in the research of ME and chronic fatigue syndrome. He's currently the medical director of Emerge Australia, which advocates for and educates about information about ME and CFS. Thank you so much for taking the time to talk to us today, Richard.
Good morning. Now, slide. So good morning all. And I'm going to try and keep this within the 40 minutes. And so there's time for questions. And very important that you get a grasp of this slide, please. Someone's pressing the slides, moving them on. And someone's supposed to be pressing the slides. There we go. Okay, thank you. My first patient with ME, myalgic encephalomyelitis, in 1981, and she was quite interesting, and eventually she did recover after about 5 years of looking after her. But I was fortunate or unfortunate to be involved with the HIV/AIDS epidemic and saw my first patient in 1983. And with that syndrome, with that disease, I saw multiple patients, hundreds of them, and unfortunately many of them died. But like other pandemics, we didn't know what it was. Then we found a virus. Then we found a test to test for that virus. Then we found some odd treatments that seemed to help. Then we set up some clinics. Lots of research was done around the world. And finally, there seemed to be multiple tests, multiple treatments, and people stopped dying. And I lost about 120 of my patients in that time. And now there's medication you can take to prevent it, and meditation, and even vaccination. So we moved out of that pandemic where 40 million people died at least. My interest was stimulated into chronic and infectious diseases, and I entered the world of ME, CFS in about 1996 because these conditions overlapped, AIDS and chronic fatigue syndrome. And I was part of the acceptance of the Canadian guidelines in 2005, where we actually had the first time we accepted a guideline which really explained what this disease was. And the most critical thing is we took out the concept of depression, because this disease is by no means a choice, psychosomatic or psychiatric. It's a biological, pathological disorder. And over the past 25 years, I've continued to work in that area and joined the Emerge Scientific Advisory Committee in 2020, and now I'm the current medical director. Slide, please. So, slide, please. Next one, that's it. So, ME/CFS, and I'll just assume, we'll just call it ME/CFS, make it easy. It's a devastating, complex, difficult, multi-system disorder. Even 50 years ago, it was recognised by the World Health Organization as a neurological disorder. And in Australia, there's over 250,000 people with ME/CFS. And now we've got this burden of long COVID, which I'll talk about shortly. And 90% of these patients go undiagnosed, 75% are women, 25% are housebound and bedridden, never leave the house. So these people are seriously ill. And according to the literature, which I have great trouble accepting, only 5 to 10% people actually recover. And worldwide, it's actually 70 million people before COVID have ME/CFS. Slide, please. So we're just going to define it. The most important thing is obviously the fatigue, you'd think. So this is not just tiredness. This is unrelenting fatigue, unrelieved by rest, where there isn't another cause. It's greater than 6 months for adults and greater than 3 months for children. It's associated with unrefreshed sleep. So you go to sleep, you wake up as exhausted as you went to bed, cognitive impairment, and orthostatic intolerance. But really, the hallmark of ME/CFS is this post-exertional malaise. You do something and you don't recover from it. And that can be as simple as getting up, going to the bathroom, going back to the bathroom, going to the letterbox, coming back in, walking around the block, depending on the degree of illness that you have. But even minuscule activities, including talking to someone, reading, watching TV, the phone ringing, all could actually add to your burden, and you'll just become more and more fatigued. And I'll talk about why this happens later. Slide. So this exacerbation of symptoms caused by post-exertional malaise is actually the hallmark. And when you hear this, so someone comes in tired, that's not ME/CFS. This is bone crunching fatigue. And the people say, and you'll see it in long COVID, I can't get out of bed. I was working, I was running, I was enjoying a family life. I could do everything. Now I can't get out of bed. I can't go to the bathroom and come back. And some of these people only shower once a week because it's too exhausting. And the sleep they have doesn't refresh them. And there's always a delayed recovery when there's a payback if you do more than you actually should be doing. Next slide, please. So part of ME/CFS in the diagnosis, apart from the fatigue and the post-exertional malaise, sleep disturbance, orthostatic intolerance, you have dysautonomias. Now, this is where your brain is disturbing the way your biological processes work. So you may have cold hands and feet. You may well have low blood pressure, and I mean low, 80/60, POTS, postural orthostatic tachycardia syndrome, where your blood pressure is very low, your pulse goes very high just from changing position, and your pulse could be 160 and your blood pressure could be 60 on nothing. Pain, myalgias, arthralgias, neuropathic pain, very common headaches, neurological cognitive impairment. So people say, I can't think, I've got brain fog. They're in the middle of a sentence and they get that thought block. They can't finish the sentence. And it's quite pathognomonic of these people. They lose their consciousness and their ability to think clearly. Neuroendocrine disorders are very common, particularly thyroid and adrenal and metabolic syndromes, and the immune manifestations. So immune manifestations, these are all the criteria you need to make the diagnosis. But these people often said, I've got the flu. My glands are swollen, my throat is sore, I've got fevers and night sweats, but it's constant and no one can find anything. Slide, please. So what is long COVID? So that's ME/CFS. So let's move straight into COVID because you're going to see a lot of this. Now, according to one of my colleagues, Martin Henscher down at Deakin University, he's predicting, because of this is prior to Omicron, between 80,000 and 325,000 will end up with an ME/CFS-like syndrome by the end of the year called long COVID. And this is the same symptomatology pretty well. There's a few differences as ME/CFS. So it's a true infection leading to a dysfunction and all the symptoms of ME/CFS greater than 12 weeks. So if you caught the infection 12 weeks ago and you're sick now and you've got fatigue and headaches and muscle pains, you can't think, bedridden, etc., that's long COVID, where there's an exclusion of other things. And I'll talk about the differential diagnosis. It's important to take a proper history, do an examination, do some pathology and scans to see if it's nothing else. But often you don't find much. You might find they've got antibodies to the COVID virus and to the vaccine. So this can happen to vaccinated people as well. But you need to think about a differential diagnosis. Next slide, please. So these are symptoms of ME/CFS and long COVID. And this is only I often say, look, tell me all your symptoms, and I go through a systems review and they'll get 50, 60, even 100 symptoms, and someone's severe. Now, that doesn't make sense. As a doctor looking for what is causing this disease, you're thinking, well, how can they have headaches and they've got joint pain everywhere and cold shakes and tremors and fevers and chest pain and shortness of breath and POTS, bowel disturbance, dysfunction with their urine frequency, urgency, and in long COVID, they often have chest pain, shortness of breath, loss of smell, loss of taste. So these symptoms overlap, and that doesn't make sense in our world in general practice, where we often see 3 or 4 symptoms. They sort of match up to something that's known, but these symptoms are multiple, and I've listed a few here, and you will be able to access my slides at the end of this talk. Slide, please. So, next slide. So, how you diagnose this? Now, we're all busy GPs, and I've been fortunate that I created time when I see a new patient. But for many of you, you've got 10, 15 minutes. So what I often say is, when a patient comes in, you've known this patient quite often, and you know they're different because they're coming and saying, look, I'm exhausted. I had COVID, 3 months ago, 4 months ago, and I'm absolutely shattered, can't get up, I'm exhausted, can't leave the bed, can't go to work. Take a bit of a history, do a brief examination, and then I would suggest invite them back for a longer consult. Maybe get the blood test done that I'll recommend in a minute. Get them back for half an hour, 40 minutes in your busy day, because that will give you the time to really nut out what this illness is. Do a full systems review. So ask them all the questions we learnt when we were at med school about every system, because you'll find symptoms in every system. Look at any pathology they've had done, scans or letters from other doctors, or do them yourself. And then do a full examination. So give them a gown, ask them to get changed, pop up on the bed. And next slide, please. Now, these patients aren't, next slide, please. These patients aren't normal. First thing, you shake their hand and they've got what I call dead fish hand. They feel like an old leather jacket, cold, clammy. Their pulse, can you go back, please? You've passed, yeah. You might take their pulse and it's very thready. Their blood pressure might be 80 on 60, and if you stand them up, it might drop even lower. So they might have POTS. So you may well do a lying, sitting, and standing blood pressure to see if they do have fast pulse and low blood pressure. They're often tender in their sinuses. Their throats are red. Their glands are up. They often have a heavy coated tongue, dry mouth, mouth ulcers, lymphadenopathy in the neck, under the arms, in the groin. And this is for both long COVID and ME/CFS patients. In long COVID, though, they often have chest wall tenderness, crepitations, rhonchi in the chest. They're coughing, but they're not infected. Tender abdomen with a loaded colon. Tender muscles. And if they've got fibromyalgia, which is slightly a part of ME/CFS, they'll have taut bands. The muscles will be contracted. Tender joints with no swelling. Hyperesthesia, that's where you just touch the skin and they're in pain. They jump off the bed. Oh, that's too painful. Don't touch me. Blotchy skin, rashes, Raynaud's of the fingers and the nose, sometimes in the toes. And they're often hypermobile patients. So hypermobile patients, those bendy people, Ehlers-Danlos, Marfan, and hypermobility patients, because of the disruption in their collagen, seem to be more prone to this. And I'll talk about this when I talk about the genes of why people are predisposed. So they've got these multiple signs on examination. Next slide, please. So now, when it's okay, you've got this patient, you've taken a history, you've got all this complexity, you've examined them, you're sick, they've got multiple things, and they've had a blood test maybe 2 months before, and it was normal, except the COVID antibodies were positive. I recommend that you do a simple blood test. Now, I know Medicare lately has been jumping up and down on people, some people who have been testing for thyroid and iron, B12 and vitamin D, but they're essential in these patients because often as a one-off, so do your MBA20, do a TSH, vitamin D, iron, B12, and celiac gene test. You're not looking for celiac disease, you're just seeing if they carry the gene. This celiac gene is overexpressed in these patients, which I'll talk about when I talk about the complexity of these patients. So that's your basic first line test, because often they'll have 30% will have disrupted thyroid, so they end up with Hashimoto's or underactive thyroid. Many of them are vitamin D deficient, iron deficient, B12 deficient. I'll explain why shortly. Now, over time, you may well do these other tests, check their zinc, ANA, if they're overweight, insulin and leptin. Leptin is a marker of obesity. So if someone's really putting on weight, and especially in long COVID, we know that many of them are ending up with type 2 diabetes and they get these metabolic syndromes. Look for all the viruses and possible bacteria that can be triggers other than COVID. So that's Epstein-Barr virus, Ross River fever, chlamydias, mycoplasmas. Those atypical pneumonias seem to be implicated. Check their urine for a undisclosed urinary tract infection, and their feces as well, because sometimes you will find bowel parasites in people, and if they've got parasites like Giardia or blastocystis, they can be pathogenic in these patients. Next slide, please. So next slide. So what's the science behind this? Now, I'm going to be very quick. I have one slide for the science because just completed a paper, which you'll all have access to. It's in publication at the moment, peer-reviewed paper, talking about what is this illness and what is ME/CFS. And my group at Macquarie University have been studying this for a while. So we've got a group looking at ME/CFS, long COVID, and something called SIRS, looking at why people react to mold. And there's even a group looking at tick-borne illness, which I'll come back to later, because there's something going on with those patients that doesn't make sense either, and other things that bite, like mosquito bites and Ross River fever, etc. Which, of course, we know some people get these conditions and develop an ME/CFS. But look, we've been doing SPECT scans and PET scans. So SPECT scan is just looking for the perfusion of blood in the body, particularly the brain, and we find they've got hypoperfusion in the frontal and temporal lobes, reduced blood flow done by your local radiology unit. And that measures inflammation in the brain, arterioles being closed down, lack of blood flow, which would explain a lot of the cognitive impairment. We've also, because all the other tests are generally normal, we've been looking at cytokines. Now, we hear about cytokine storm in COVID in hospital, and they have a cytokine storm. That's what kills people, because those cytokines go extremely high. That damages the lung, the heart, the kidneys, the skin, which is why people end up on ventilators, because they're liquefying their lungs and bleeding out there through their blood vessels. So these cytokines are raised. But in long COVID, ME/CFS, and a small group of patients post-vaccine long COVID, and I'm seeing a few of these, not many, but there seems to be people who have the vaccine have developed this condition as well. And there's a range of cytokines, which are these inflammatory chemicals coming out of your white cells that should go up, what are called pro-inflammatory cytokines. They get turned off by anti-inflammatory cytokines, go back to normal. Part of your natural defense mechanism, healing mechanisms, but they stay turned on. And we think that's why these people have got multiple symptoms in multiple areas, and any tissue or organ that's inflamed, where there's cellular dysfunction, are the symptoms they're experiencing, which explains the multitude of symptoms. We're also looking at tryptophan pathway. That's the pathway in your cell that leads to the production of melatonin, serotonin, and particularly activation of your mitochondria. So if your mitochondria is dysfunctional because you produce what we call quinolytic acid. So as I said, the science is getting complicated here, but quinolytic acid is an abnormal byproduct of tryptophan. If that happens, it disrupts your mitochondria. You'll get low energy, you'll drop your NAD, which is a vitamin B3 activating your mitochondria. And that leads to cellular failure or cellular dysfunction. The sum total of all those cells not working properly is the fatigue you're experiencing. Okay, this is why it's a different illness. It's something we're starting to understand why we've never been able to work it out. Multinomics, that just means looking for different proteins, particles, bacteria, and viruses in blood, which we are doing. I'm working with Eddie Holmes, Australian Scientist of the Year, and he and I have been working, trying to find, is there any of the COVID left? Now, at 3 months, there's no COVID virus left in the body except in the bowel motion, maybe, but it's not in the blood. But there are particles of the COVID virus still left in the cell and in the body, and we're developing PCRs, new serology, cellular techniques. And obviously we've got new serology just for COVID. You know, we didn't know about COVID antibodies. Now we can see if you've had the infection or had the vaccine. Next slide, please. Next slide. I'll miss that one. So next one, we get through all this. Now, what's the differential diagnosis? Now, we're all good GPs, we're all busy, but these other things that are listed on this slide, I won't go through. Need to look for heart problems and lung problems and metabolic problems and psychiatric illness and all these other things. But the thing that's most missed in my practice over 25 years is celiac disease. Now, celiac disease, 30% of the population carry this celiac gene. 1 to 4% of people carry will develop celiac disease, which we know is diarrhea and weight loss and in children and bloody motions and failure to thrive and all that. But some people present as adults and they don't have any gut symptoms at all. They present with fatigue, pain, cognitive impairment, all the same things. And you do a biopsy, and yes, they do have, you send them to a gastroenterologist, you find they've got loss of cilia, but they haven't manifested gut symptoms, which doesn't quite make sense. But and 10% of my patients I've seen over the last 25 years ended up having celiac disease, and they respond to a gluten-free diet. So we'll come back to this because this is important. So sometimes celiac disease can be missed. These other disorders we have to look for before we actually diagnose ME/CFS. Next slide, please. Next one. So this little nomenclature I'm going to give you is how do you break these down? So someone's come in with, say, 30 or 40 symptoms. You know this person well. They're not a malingerer. They obviously look sick. You've examined them. They've got these vague clinical signs and they're not well. So how do you break this down? Next slide, please. So these little thought processes, slide, thank you. So these little 11 breakdown points, they'll have 2 or 3 of these each patient. The first thing is when you've taken the history, find out when were you last well? And they say, oh, look, I got mosquito bite, I got Ross River fever, or I had glandular fever, or I had an atypical pneumonia, with mycoplasma or chlamydia pneumonia, or you're a bird fancier and you keep birds and you get psittacosis, bird fancier's lung, which is another chlamydia. Or latest kid on the block, COVID-19. I got COVID-19 4 months ago and this is how I am. So always look for these viruses because it might give you an idea. And sometimes you'll find in some patients, they've got IgG and IgM as if they haven't eliminated those infections. So just be aware, in some people, these infections seem to persist, particularly Epstein-Barr virus, which is being reactivated in 60% of people with long COVID. Okay, so we're getting complex here, but we'll keep going. The gastrointestinal issues these patients have, many of them will have food and chemical sensitivity syndromes. They say, I can't eat wheat, I can't eat dairy, I'm struggling when I eat sugars and different things. So listen to them and say, well, stop eating them. They may well have bowel dysbiosis, that's imbalance of the bacteria in the gut, which is really important, because especially if they've had lots of antibiotics and things, and you may be able to correct that with a simple probiotic. But the serious ones end up with gastroparesis and severe slow transit constipation. Don't open their bowels for 2 weeks. So they're seriously ill, and that group can become life-threatened because they waste away and they can get bowel obstruction. So just be aware, these are rare, but I want you to be aware that these people have all degrees of this. Next slide, please. So the endocrine disorders I mentioned, underactive thyroid. Now, 30% of people who have ME/CFS, and I suspect long COVID, will end up with Hashimoto's thyroiditis because they get inflammation of their thyroid as part of this inflammatory response, or just small thyroids leading to hypothyroidism. That's why I do the TSH in the first instance. They definitely can develop adrenal insufficiency, whatever that is, and they say, I'm running on adrenaline. And some of them will end up with Addison's disease. And I do have a very supportive colleagues, endocrinologists, that I refer these patients to confirm this. But the one I want you to really think about is type 2 diabetes. If you've got long COVID, we think, particularly men, are ending up with type 2 diabetes. We don't know the percentage. None of us know how many people have got long COVID, nor do we know how many are ending up with activated Epstein-Barr virus, type 2 diabetes. But I know from my ME/CFS patients, it's probably 10% will get diabetes or at least severe metabolic syndrome. Leptin resistance, which is where they can't metabolize fat, so they just put on weight around the middle, and they get more pain. The bigger they are, they have more pain because they're not able to metabolize their fat, and that's due to inflammation and reactive hypoglycemia. I'm not going to talk about that now. Sleep dysrhythm, they have circadian dysrhythmias. Check for sleep apnea, central and obstructive. Next slide, please. Dysautonemias, which I mentioned, hypotension, low blood pressure. I mean, serious hypertension. Very common in COVID patients. Long COVID patients often present with POTS, and they have low blood pressure sitting. So you lie them down, it's a little bit high, you stand them up and they almost pass out. You can do a tilt table test, but I'll talk about that later. But very important, if their pulse goes to 160, they're in trouble because they can't walk around, and there are ways you can manage this Fibromyalgia. Now, fibromyalgia is where they have the pain is dominant. They've got taut bands in the muscles, fatigue and sleep disturbance. I know this is complicated, but if you put them in these little, easy to work out what to do with them. Then you look at the genetic disorders, and what's the most common genetic disorder in these conditions? They carry the celiac gene. We think it's around 50 to 60% of people with these disorders carry the celiac gene. It's overexpressed, and they're not celiac. They just happen to carry that gene. And that comes from the Roman times, and Romans roamed and went around the planet and, left their genes. And this is in all cultures, and don't have to, you can be Chinese or from the subcontinent, India or wherever, you can carry the celiac gene, and it is relevant. Marfan syndromes, Ehlers-Danlos, hypermobility syndromes, remember those? I won't go through the mitochondrial disorders. They're just representative of people who don't have ME/CFS, but they do have something else and they progress to death early. But they look like ME/CFS patients in the first instance. Next slide, please. Now, the surgical conditions. Now, this is, as a GP, I want you to all realise that if someone comes in and they've got long COVID, ME/CFS, and they've got rotten, nasty-looking tonsils with crypts and pus, and they're constantly saying, I constantly get sore throats and the tonsils are really large, they've been like it for years and I've had it all the time, organise a neonatal throat specialist to see them. And if you remove their tonsils, you remove some of the biofilm or collective bacterial virus that's present in that lymphoid tissue, and some of these patients will improve. So just if they've got nasty tonsils, I'm not saying just a bit of sore throat, I mean damaged tonsils. And the same goes for dental infections. So again, if they've got infected teeth or impacted wisdom teeth with infection, or particularly chronic cholecystitis or chronic appendicitis, those people with gallstones keep getting gall attacks, people keep getting recurrent low-grade appendices attack. Removing those diseased organs in some patients improves their ME/CFS. I don't know about long COVID yet, but it seems to be a lot of chronic tonsillitis in those patients as well. Arnold-Chiari syndrome, rare condition where you herniate the back part of your brain due to increased brain pressure. But again, it requires surgery. Now, this is an unusual one. It's not gazetted anywhere yet. It's called chronic inflammatory response syndrome. This is where people react to mold. Now, if you're up in the Northern Rivers or Queensland at the moment, in the flood areas, people living in tents inside their mouldy houses, they're not only getting aspergillus lung and black fungus lung and fungal infections, they're actually developing a toxic response to the biotoxin from the mold. And this was studied in a Senate inquiry. We tried to create a name for what this is. It's something we're researching at Macquarie Uni. We're not sure exactly what to do with this, except get people out away from the mold at the moment. But this is a real condition. And if you're living in an area where there's been a lot of rain, there's mold in the house, get that mold, advise your patients to remediate the mold, get rid of the mold in their houses, because it actually could be toxic to them. And again, more likely if they carry the celiac gene. Next slide, please. Now, this is the last two, the neuropsychiatric chronic fatigue patients. Some of these patients will present with low mood, anxiety, but some will be ODD, OCD, psychosis, extreme panic disorder and anxiety, which they weren't before getting this illness. Now, this is not the cause of ME/CFS. This is because, as I talked about the SPECT scans in the beginning, their brains are inflamed. And when you've got inflammation of the brain in those cognitive behavioral parts of the brain, you'll get disrupted function leading to these symptoms. So when you see these patients, you need to think, okay, this is not normal. This guy, I've known him for years. He's a hard worker and he's happy and whatever, and he's really depressed. He's having panic disorder, can't sleep, in pain, brain fog. He has long COVID, and we do treat some of these symptoms, and this is why I've created this nomenclature. If you know this central part, you can do the next part, which is basically looking at treatments that you can modify some of this. And the last kid on the block is long COVID. So you've got multiple ME/CFS symptoms, severe inflammation to tissues and organs. And if you've been in hospital intensive care, you're damaged heart, damaged lungs, kidneys, skin, brain, which you may never recover from completely. And some people obviously are passing away with this, but some people are profoundly disabled. And if they've got long COVID after that, they're slightly different from because people can get long COVID even just having a mild illness. 3 months later, they're still really sick and get worse. But someone who's been sick in the beginning is obviously going to be quite sick for a long period of time, more than 3 months. Next slide, please. Next slide. So this is the most important to take home. Apart from, so you've got the diagnosis, you've done the examination, you've thought about it, okay, excluded anything else, you've got someone sitting in front of you. Now, the first thing you've done by listening to the patient and you know this patient or you don't know this patient, you've made extra time for them, you seeing them and sticking with them is the part of the therapeutic process. I often say if every doctor took on 4 to 6 ME CFS patients and now long COVID patients, every patient with ME CFS would have a doctor. Remember, 90% aren't go undiagnosed and aren't seen. So it's up to not an individual like me, but it's an individual like me to teach you and give you courage to take these people on. They are incredibly thankful as you take them on. And look, the first thing you've got to do is resuscitate them. So don't go for the jugular and try and treat everything you see. First thing you do is make the diagnosis. You educate the patient. You treat the symptoms you can, and you might treat the cause later. You recruit a psychologist, and a psychologist is not there to do cognitive behavior therapy. It's just supportive therapy. Get social workers involved. You do need to try and help them deal with all their complexity because they need carers. They may well need pensions and NDIS and their insurance forms filled in. And please contact Emerge Australia, which I'm the medical director of, because they have educating nurses there to help you, guide you in this process, the patients, and they'll help them out with various things and line them up with other support services, etc. So, and you can contact them as well and maybe become registered with Emerge Australia, so you become one of those doctors that patients can go and see, because you're accepting that there is a body of patients out there that need our help as GPs. Next slide, please. So the first thing I would categorically say, if you've heard that cognitive behavior therapy and graded exercise is part of the treatment of these conditions, I categorically, in this moment, categorically say it's absolutely wrong, unscientific, unproven, and never should be recommended for these patients. I can't impress on you more than that. It's not in the American NAM guidelines, the National Academy of Medicine. It's not in the NICE guidelines from the UK, the National Institute of Health and Care Excellence. These guidelines, recently published, last one in November 2021 from America, categorized these treatments should not be offered. They are not helpful. Pushing someone past their limit doesn't improve them. They've got cellular dysfunction with inflammation, and telling them that's in their head and you've got to try and push yourself and get above this is absolute nonsense. It's unscientific and needs to be removed from any guideline anywhere in the world. Somehow we seem to still have it here. And I would say, as an ME CFS doctor, you're going to damage your patient if you recommend this. It doesn't help. And it doesn't, the patient know it doesn't help. They won't do it because they'll collapse and get worse. Next slide, please. So what do you do? Well, you talk about pacing. So pacing is not graded exercise. Pacing is, look, you're not well, let's try and get you to do 80% of capacity, because you do want them out of bed. You do want them doing something. But if you're out of bed and you can do a little bit, if you're starting to get tired, you've done 80% of your capacity, you rest if tired. Get a mental health worker, a psychologist, someone involved, but you're not doing cognitive behavior therapy. You're just supporting them through the process, trying to help with their deep pain and emotional loss. They're grieving having this illness, but you can't talk them. Talk therapy will not get them better. They've got a brain that's inflamed and dysfunctional and a body that's doing the same. So pacing and supportive psychological therapy is what we do, not graded exercise or cognitive behavior therapy. Next slide, please. So obviously I've talked about, getting the psychological support, get the social worker and an occupational therapist, get their home checked to see if they need rails or special beds that lifts them up or whatever. Get the support groups. Support groups are very helpful because they feel very alone and lost, these patients. Pensions, NDIS, insurance, it's an absolute minefield. But Emerge Australia, the peak patient support body in Australia, is there to help them. And that helps you as GPs. So having that referral service, and oh, look, here's Emerge number, contact these people, they will help you. You've started their journey of healing. Next slide, please. So let's talk long COVID, because you're all here, because you've got to see long COVID. If we're going to end up with 325,000, according to Martin Henscher, by the end of the year, we're in trouble. I hope he's wrong. But there are a lot of patients with long COVID. Now, I'll give you the statistics. If you're not vaccinated, between 10 and 30% of people unvaccinated will get long COVID. If you're vaccinated, we think it's 5 to 15% of people vaccinated will get long COVID. If you're vaccinated and receive an antiviral agent, it seems to be 5% and less. Now, we're not obviously giving all our patients with COVID antivirals, but our sick patients who are over 65 or have the criteria for prescribing molnupiravir or one of the other antivirals, they may not develop long COVID. And if you've got ME/CFS or a chronic illness already, you're probably more prone to get long COVID. So there's some rationale in doing that. Definitely involve yourself, you and the patient at the core of their treatment, and very important that you involve allied health and all the other things we've talked about. And know out there that we are doing research all around the world. I talk to colleagues, I'm doing stuff all around the world to help us understand what this illness is and what's world's best treatment. Next slide, please. Now, I'm going to put a disclaimer to this. This is what I'm doing. Now, I've managed to talk to colleagues. I've read every paper known to man. I read 2 papers a day trying to understand what are we going to do about long COVID and what's the world's best treatment. So I gave this lecture a week ago and I've added a couple of things, or this looks like the old ones, but you can treat these conditions by lowering the inflammatory response. So you can use dexamethasone, 0.5 milligram, 1 to 2 for 10 days, half to 1 for 10 days, so total of 20 days. That'll dampen down the cytokines. Pravastatin, which is a statin for cholesterol, 10 milligrams given at night, reduces some of the cytokines. So evidence-based in research which is being done around the world. No one has published a paper, this is how you treat long COVID. So I'm giving you, this is what I'm doing, gleaned from the best doctors I've been able to follow. And some of these doctors have got 20,000 patients in their cohort doing this. Fluoxamine, which is an antidepressant, 25 to 50 milligrams twice a day, again, reduces cytokines. Give them aspirin. Patients with long COVID produce microclots, and that's part of the reason their organs are getting damaged. Make sure they don't have Helicobacter, because that's very important. If you give aspirin Helicobacter, they'll bleed, but generally only 3% of people on aspirin bleed. And you only give these treatments 4 to 8 weeks. It's not as if you're giving them. They are off-label. They are not gazetted. And I put a little disclaimer in those lecture slides, but that's all I can do at the moment, because it's very important to realise we're doing our best without the knowledge of hindsight. So I'm sure in a year's time, we'll have a gazetted guideline which will guide us a bit better. But this seems to be working in our patients. They do develop herpes virus. Many get shingles, cold sores, genital herpes, Epstein-Barr virus, cytomegalovirus reactivated. Valcyclovir is useful in those patients, say with shingles and genital herpes, off-label in other herpes viruses, particularly cold sore virus, because they're not just a couple of cold sores, they could be a face of cold sores. And again, supplementation. Melatonin seems to help with sleep, and something called glutathione, which helps reduce the reactive oxygen species oxidative stress in the body, can be given as N-acetylcysteine, 500 milligrams twice daily, converts to glutathione. It's a tripeptide, reduces inflammation. And these patients seem to be low on it. Just some of the studies I've been looking at. Next slide, please. So if you do those things for 8 weeks, you may get somewhere. But these are the things that I do for my ME/CFS patients. I'm going to go through these because I've got 11 minutes, so I'll give them a minute each. Get them to, they'll tell you they can't eat certain foods. And so I eat gluten, I feel really sick, it gives me diarrhea or bloating, or I feel worse. You can support them stopping it. They're not necessarily celiac, but they can stop it. That seems to be universal, especially the ones that carry the celiac gene, but they're not celiac. Definitely, particularly sugars and lactose seems to be associated with that. There are doctors and clinics around where people have multiple sensitivities to foods, and FODMAP diet, which is an anti-inflammatory diet for people who carry the celiac gene, paleo diets for those who are overweight. But I want to get to this red meat-free diet. Now, a colleague of mine, Cheryl Van Noonen, has developed a test called an anti-gal test, looking for people who've had tick bites, and they've developed meat allergy to beef, lamb, and pork. And they get anaphylaxis or severe allergic reactions, but they also seem to have ME/CFS. So just be aware of those patients. We're investigating this. We're trying to work out, why are these people sick looking like this, but get them off their meat, because even a little bit can make them sick. And then supplements. There's thousands of supplements for these conditions. I don't think many of them work very well. People spend a lot of money, and often they get to you and they've got a bucket load of supplements. Look through them, be rational with it, and support them not taking so many things. What I find is useful, though, is iron, because they're often iron deficient. B12, they're B12 deficient. They're malabsorbing it. Vitamin D, because they're probably locked up in their rooms, not getting sunlight. Magnesium helps at night. Zinc helps their immune system. So they're the ones I give. Available local chemist or local health food shop. They're useful. One a day, just give it 2 a day of the magnesium at night. Good probiotic from your health food shop or from your chemist or whatever. Useful, helps with the gut function. I'll move on past that. Next slide, please. Sleep is very important, regular hours of sleep. And I won't go too, but the most important thing is get them to quiet room, dark room, and generally try and have a reduced stimulation at night. Give them some magnesium, melatonin. You can use amitriptyline, very useful. And if their sleep and anxiety is so severe, you can use olanzapine. If they're having seizures and twitches and fits at night, very low dose clonazepam is helpful, and something called low dose naltrexone. Now, it's in the latest guideline out of America. Low dose naltrexone is a drug that naltrexone blocks narcotic use in people who have got addictions. But if you use low dose, it affects the GABA pathways, reduces inflammation in the body, improves sleep, stops pain. Next slide, please. Pain management, again, they've got 5 sorts of pain. It's inflammatory, neuropathic, myalgic, arthritic, and headache. Use simple analgesics. Don't use narcotics. I think people get pregabalin is evidence-based, particularly for fibromyalgia, and low-dose naltrexone seems to help. And you will get a copy of these slides. Next slide, please. Mood disorders, very important. Now, in mood disorders, obviously get them supportive therapy and whatever, but escitalopram helps because it's evidence-based for controlling the POTS, so it helps dysautonomias and will help with sleep and anxiety. And duloxetine, evidence-based again for fibromyalgia, 30 to 60 milligrams taken in the morning, will help with pain, improve sleep, and then some of these other things to reduce anxiety. And you can use off-label, low-dose antipsychotics, but very low dose. Next slide, please. Thyroid, just remember, 30% of people end up with thyroid issues, so I give them thyroxine. I check their thyroid. I always do a scan. And of course, refer to a colleague if you're not sure. There is a role for T3, which is this triiodothyronine activated thyroid in really small group of patients. And they're the ones who presented with a temperature of 33 to 34 degrees. They say, I'm cold all the time. You check their temperature and it's subnormal. Again, you need to get advice from your endocrinologist colleagues. Next slide, please. Adrenal insufficiency, quite real. I measure it. Do a morning cortisol. Often it's low normal. 24-hour urinary cortisol can be very low. Short symptoms, yes, sometimes, yes, thank you. And I give small doses of cortisone, and monitoring is very important. Next slide. We're nearly there. POTS, I manage POTS now. Most important thing, get them in stockings, 20, 30 millimeters of mercury, short leg stockings, plenty of fluids. Definitely you can give them lots of fluids and salts, and you can use fludrocortisol, midodrine, which is an alpha blocker, increases their blood pressure. Propranolol slows their pulse, but avabradine is evidence-based, and they seem to get better with avabradine. Used for congestive cardiac failure, off-label in this condition, very helpful, slows their pulse, and the midodrine Fluoref gets the pulse, the blood pressure up. Next slide, almost there. Gastrointestinal probiotics, definitely get their bowels working. If they've got constipation, slow their bowels down. If they've got diarrhea, look for parasites and other causes of this. Next slide. And infections, last slide before the very last one. Now, infections are really important to think about because some of these people will have persistent infections. Now, with long COVID, we thought originally that vaccinating them would help the long COVID. I still vaccinate my patients with long COVID. Most of my long COVID patients have now had 4 vaccines. I am using Novavax as my 4th vaccine. It seems to not activate the cytokine inflammatory response. Because remember I mentioned there's some patients who are post-vaccine long COVID, not common, but I've got a few of them. They also respond to this anti-cytokine inflammatory response syndrome type treatment that I've mentioned. But definitely look for mycoplasmas, chlamydias, and they've still got IgM positive, Ross River fever, Epstein-Barr virus. Hard to treat because we don't have treatments for them. Look for bowel infections and parasites. I generally follow the evidence-based treatment for bowel infections. If they've got Giardia, blastocystis homicidis, they're probably right treatment. And definitely look for urinary tract infections. And something called biofilm. That's why I take out the tonsils, the gallbladders, the teeth, and the appendices, because often that's a biofilm feeding into the body. Last slide, please. So, complex illness. I know this has been a bit of a rush, but look, ME, CFS, and long COVID are related disorders. They're the same disorder, really, just a different cause. They're incredibly complex and debilitating, but from my point of view as a doctor, as GPs, this is a GP illness. We take on 4 to 6 patients, we work through them, we support them, we learn how to do this. You've got my slides, I've got papers coming out, and I'm going to ask the organisation here to send you the NAM guidelines, because we're giving it out to every patient, every doctor in Australia, and that's everything I've talked about here in that. So there's no question about that. There are guidelines and treatments available which are worldwide, which I'm talking about, that other doctors are talking about as well. So the current NAM guidelines has just come out. All patients deserve medical, allied health, social and financial support. They cannot be abandoned. It's our role to look after them. We're in the hub in the middle. We feed out to everybody else. And generally, in my experience, my patients have been my greatest teacher. Not only do they research things and whatever, but they'll soon tell you if something's not working or is working or whatever. And the greatest joy in treating these people, I see far more people recovering from this illness to some extent, or sometimes completely, than 5 to 10%. So I suspect that statistic's wrong, but I suspect it's there because they do need a medical approach. It's not, they don't respond necessarily to supplements and naturopathic treatments. They're helpful, but these are medical problems with medical conditions that need medical treatment, and the best people placed to do it are us. So that's the end of the talk, and I'm very open to questions, and I hope you get the slides, and I'm hoping to organise for all of you to receive the most latest NAM guidelines. It's worth a read. Thank you.
Thank you so much, Richard. Very complex disorder, which I think we need to get our head around.
Oh, I know. Sorry. That's the shortened version.
Yeah. Katrina has just told us that we will send guidelines with the post-conference email with probably all your slides, because there was so much information there that
I'm sorry it is. But it is. You need to learn a lot about this condition if you're going to. And look, all of us are capable of looking after it, and just start low and slow. Just accept they've got it and don't send them off for greater exercise.
I think that was that use us being able to see them and stick by them, and I guess I feel like there's been a lot of judgment. Perhaps I think a lot of people have been quite scarred from medical professionals.
I've got a name for it, but I won't mention it here. It's not fair because it comes from just lack of training. Look, I'm going around Australia teaching as many doctors as I can. That is my role as medical director, and I'm not taking new patients, but I'm training other doctors. I'm trying to get all of you on board to help look after these patients, because if we get those huge numbers of long COVID, we're in trouble medically.
So we have got quite a few questions, so I'll try and whip through them. What is the current thinking around protective benefit of vaccination prior to COVID infection, relationship with long COVID? Any analysis yet?
Rule of thumb, this is coming out. England's producing the best statistics in relation to COVID, long COVID, and what protects you, what doesn't. So if you're not vaccinated, your risk of getting long COVID is 10 to 30%. If you're vaccinated, your risk goes down to 5 to 15%, and I suspect it's less if you have an antiviral when you have COVID when you're vaccinated. The more vaccines you have, the less chance you have of long COVID. You should be on your 4th vaccine for everybody, and you should mix your vaccines up. Don't give everybody, and if you're under 18, we the messenger RNA vaccines, but I think Novavax and AstraZeneca have actually been 2 better vaccines because they actually give very high levels of T-cell immunity. They might have lower antibody response, but the T-cell memory seems to be longer. And unfortunately, the research hasn't been completed with Novavax, but if you've got access to Novavax, I'm advising my patients to have that as their 4th or 5th vaccine, because I think it just adds to a mix, because it works, because it's a bivalent vaccine. You've got two spike proteins which they're following from with, and they can change them with the variants, and that's very clever technology.
I want to keep moving through them. But in relation to investigations described, what do we need to tell our patients about MBS rebates? Because obviously some of them won't.
Yeah, this is really good. There's 5,000 doctors, unfortunately, have just received letters to say you're doing too many iron, B12, folate, iron, B12, thyroid, and vitamin D. Look, if you do it once on a patient and you've got 4 or 5 of these patients and you don't do it normally, I don't think you have a problem. But if you're someone who's doing that regularly on multiple patients, you're going to get pinged. And what I do, 2 pathology forms. This is your public one. This is covered under Medicare. I write a private one. I put private, charge the patient on it, and tell the patient they're going to get charged. That'll save you from being in trouble. If you feel not comfortable organising a celiac gene test, iron, B12, vitamin D, TSH, privately bill it. Tell the patient. If they're not, but if you're not doing it too often, I don't think you'll be in trouble, because you're not going to be seeing hundreds of ME CFS patients where I'm saying that's required. You might see 4 or 5. So if it's not your habits, you're probably fine.
I'm going to miss your. I'm trying to keep the questions that you can be answered, because we've got 1 minute. In a patient who has complex psychiatric and gender issues prior to the chronic fatigue and is seeing a psychiatrist and psychologist, what is your recommendation for treatment for CFS?
Oh, absolutely. I mean, the first thing is you're collegiate with your colleagues. And if you've got someone who's life-threatened and they've got transgender issues, or particularly psychiatric issues as well, the primary need of care is to keep that person safe. So you have your psychologist, psychiatrist, you have a conversation with them, but then you do the normal things you would normally do. That's why I gave you that nomenclature. So if you find they're iron deficient, or they carry the celiac gene, or they're vitamin D deficient, or they're developing underactive thyroid, you manage those the best you can, but as a collective with your psychiatrists and psychologists. Everything is done collegially. I work with teams in all this, which I just refer out, and I have psychologists in my practice. So they're paramount. If someone's life-threatened from their pre-existing pre-morbid condition, you put that first, but then you still need to manage their ME CFS.
Also, good question here. Given that many CFS have immunocompromised and impaired killer cell function, why is this not included in the ATAGI COVID vaccination criteria or oral antivirals?
I will take that. I will look at that in another way. I think this is an immune activation disorder. It's not. Normal ME CFS patients will not catch other infections. They actually have good T cells. They have diminished CD57 counts. That's a natural killer cell. They get used up fighting whatever stealth infection that may have caused their illness. But their T cell function, their immunity is switched on. They've got high levels of inflammatory cytokines protecting themselves. The dual sword, though, it's damaging them. So, it's hard to answer that. I don't find many of these patients are immunosuppressed or have, but they will end up immunosuppressed if they last long enough, and they get IgG subset deficiency, but their T cell function is dysregulated, but it's not deficient like you see in HIV. It's more their immunoglobulin disruption. And many of these patients actually respond to immunoglobulin therapy, especially if their subsets are very deficient. So, I think they're all different. So it's hard to answer that question.
Yes.
Because I think they're immunoactivated.
We might have to stop you there. I mean, it's such a big area, isn't it? But thank you so much, Richard, for sharing your expertise. Yes, I also want to thank the Australian College of Rural and Remote Medicine, who have sponsored this talk. Now we have 20 minutes break, I think. So take the time. So we start back again at 12:10. So but 15 minutes. So grab a tea and coffee, stretch your legs, make sure you're ready for the next talk, which will be on mental health. And now click the button that says exit on your top left, and then you'll click on the next session. But thanks again, Richard. A great talk, and
all the best.
We'll be hearing more.
We are getting the science out there to help you.
Yeah, well done. Thank you.
As well.
All right. Cheers.
Okay. All the best. Take care.
Thank you.